Thank you for the invitation to speak, and I will try to discuss some items related to anti-NMDA receptor encephalitis. And about halfway, I will stop with the talk, and I'll have also some cases that we can discuss about considerations. It's all clinical, so feel free to discuss any considerations you would have related to those cases. Let's see, where is it? My disclosures. Importantly, I will discuss immunotherapies, including the inebilizumab trial Extinguish, which I'm a co-PI to, and I will also discuss the PROS, patient-reported outcome measure, that we have a copyright about, so important to disclose. Of course, I'm not going to a lot of details on like what autoimmune encephalitis is. I will directly delve into anti-NMDA receptor encephalitis that was discovered almost 20 years ago by Joseph Dalmau in 4 young female patients with ovarian teratomas that had a multitude of symptoms that led to encephalitis, and after removal of the ovarian teratoma and treatment with immunotherapy, those female patients recovered. Those were only 4 patients. At that time, it was not known that it was the NMDA receptor the antibodies were aimed at, which was published in 2007. And this led to the quick identification of a lot of, many more patients. And what we've learned then since is that about still the median age is about 20. Most patients are female, about 80%, but also we see that about 25 to 35% of the patients are children, and within childhood the difference between male and female is less pronounced, and also over 45 we see that it's less pronounced female preponderance, and also that the amount of tumors differs by age category, where the numbers about the teratomas have gone down over time. 12 to 50, 45, it's still about 35–40% having teratomas, but if you look at children under 12, it's rare, luckily, and over 45, we're not talking about teratomas, but generally about carcinomas in about 1/4 of the patients. And also an important difference over the last 10 years is that when we published this 10 years ago, it was 5% of patients were 45 and over, but if we currently look at our patient data, about 15% of the patients are 60 and over. And I will show you in a few minutes that those patients are a little bit more difficult to distinguish from all the other diagnoses that you could consider in this age group. So what are the initial symptoms? About 2/3 will start with behavioral symptoms, and a smaller part with seizures and movement disorders. In young children, we see that this is a little bit different. About 1/3 will start with seizures, another 1/6 with movement disorders, and only 1/3 with behavioral symptoms. Adolescents, 12 to 18, are a little bit in between those children and adults. But also if you look at 45, it's less pronounced. We see less seizures as initial symptom, and mostly memory and cognition and behavior. And this is, of course, much more reminiscent of basically sort of like a depressive-like behavior, burnout, early dementia. So you can imagine that these symptoms are less distinguishing between the other disease that you could consider. If we look within a month, the general picture is that most patients have multiple symptoms, and there's also a difference between the different age groups, especially speech and movement disorder. And in speech, it's often mutism or less speech this might be an important hint in patients that have predominantly psychiatric symptoms, as many of the patients with a primary psychiatric psychosis will have more speech, while in NMDA generally it's less speech. It's more pronounced in children, speech and movement disorders, while memory and hyperventilation are less pronounced in children, and the atypical symptoms like cerebellar ataxia or hemiparesis are rare and generally seen in children under the age of 8 or 12. If we look at patients 45 and over, what we can see is that they have less seizures. Similarly to the initial symptom, within a month, it still remains that less than half the patient will develop any seizures. They have less groups of symptoms compared to the adults and children. And as a consequence, and also as a consequence of the longer differential diagnosis, the delay until diagnosis is much longer, almost 2 months versus 3 weeks in patients under 45. So there is definitely some ways for improvement there. If we look at the severity, what we can see this is generally most patients will develop a multitude of symptoms, as it's not only a limbic encephalitis, but a panencephalitis. And in 2013, we published that about 3/4 of patients would end up at the ICU, and 90% would be MRS5, like an almost maximum MRS, all dependent for everything on others around them. If we look at more recent data, and this is data from our center, but these are quite similar to what others have published, for example, the Generate from Germany, or other studies, they show that this has gone down to about 50% ICU in general, and a median MRS of 4 at time of diagnosis. So apparently we have been able, over the last 15, 20 years, to increase our diagnostic accuracy, earlier treating, but also wider reconnaissance of the different patients. If we look at the ways to diagnose NMDA, most of the times there are some abnormalities, but this is not always true. As you can see, that the CSF abnormalities are abnormal in almost 80%, but generally they're not that outspoken. So there is some pleocytosis in 75+%, but generally it would be around 30, 40, 50 cells, but also can be like 8 or 12 cells. MRI is generally normal. Most patients have a normal MRI. If you look at the first MRI, if you look in the full spectrum over time, then more patients will develop some abnormalities over the full course, but only 1/3 will show abnormalities beyond like the regular things you would expect at the age for that patient. EEG is generally abnormal, but not always, about 90%, 90+. But this can be seizures, but that's a minority. But generally it's about slowing, and this can be diffuse slowing or focal slowing. Of course, the extreme delta brush has been published or discovered in 2012 by Schmidt from the NYU, but in Colombia. But over time, we've also seen that extreme delta brush is much less frequent than initially thought, and most studies describe like 5 to 10% only of the patients exhibiting extreme delta brush. So it's rare, mostly seen on the ICU, and there's a difference between extreme delta brush, where you have the deltas, and at some part of the delta you have the beta brushes, like you see here in this example, versus a patient with delta brushes showing slowing for a patient, general slowing, and beta brushes all over the EEG due to all the benzodiazepines that patients receive. That's not extreme delta brush. That's just a mixture of two different types. But extreme delta brush is like a only up or down on the delta brush. On the delta wave, you see the beta brushes. Important to consider, if we consider the commercial kit, the Autoimmune CBA, only 2/3 of patients will have antibodies in serum. If you're using in-house CBAs, like some of the research laboratories do, then you can get this percentage up to like 80–85%. But the gold standard is CSF antibodies, as they are. And so if you have a positive result in serum, but no positive result in CSF, you should seriously question the value of your antibody result. So altogether, we have this phenotype where patients often develop a viral prodrome. This is non-specific, and then they develop one symptom, and then there's like this house of cards that is like building, and multiple symptoms occur, and within days, 2 weeks, patients might end up on the ICU developing more and severe symptoms with autonomic symptoms, sometimes even asystole, hyperventilation, and multiple seizures, necessitating multiple IV drugs to stabilize the patient, and sometimes even temporary pacemakers. This episode of severity can occur days, weeks, or sometimes, luckily only sometimes, months. Our max is about 15 months on the ICU. And then the patient starts recovering, and the recovery is in the opposite direction from the initial development of symptoms. So the last symptoms are the first to go, and then you have this long time of recovery where patients generally have memory issues and behavioral issues. And sometimes even this new onset of behavioral symptoms because of their apathy and because of their encephalopathy becoming less outspoken is considered a relapse, but this is part of the recovery process, that if the patient starts to become more active, that you can also have more outspoken psychiatric features. And if we are considering this long-term outcome, of course, before we have the phase of treatment, and we have often we need to consider the tumor. If there's a tumor, of course, you have to remove it, but there's also almost always need for symptomatic treatments. There could be anti-seizure medication, antipsychotics, medication to stabilize the noradrenaline, or benzodiazepines, or all these symptomatic treatments, but also immunotherapy. And if we are looking at patients overall, we see that about just over 80% will be independent for activities in daily living after 2 years. What you can also see is that it can take quite long to achieve this. We're using here the modified Rankin scale, which of course is a crude score developed for stroke, so it's not at all suitable to be very well equipped for NMDA receptor encephalitis, but still, for the purpose now, I'll come back to that in a few minutes, but we will use this one. What's important is the earlier you start with treatment, the better the patient will do. And there's also like quite a clear cut. So about half the patient will respond to first-line immunotherapy consisting of steroids, IVIG, or steroids and plasma exchange within the first 2 weeks. So you see a clear improvement within 2 weeks. And those patients generally tend to do quite well. So after 2 years, 97% of the patient will have returned back home. And unfortunately, that also implies that there's another half of the patient that do not directly start recovering. And what we see in those patients is that they have a longer admission, longer times of recovery, less favorable outcome. And those are patients that it's clear that they do benefit from second-line immunotherapy. So if we look at what our data do we have related to the second-line immunotherapy, and this, of course, there's no trials yet that have been finished to compare these different treatment regimes. But what we did back then, already over 10 years ago, was that we looked at patients that had not improved after 4 weeks. And then we said, okay, what happened next? And we split the group in patients that had no additional treatment, although those were rare. Most of them had additional treatments. So they switched from IVIG to plasma exchange, or from plasma exchange to IVIG, or they repeated IVIG and plasma exchange, and so on, or steroids. And if we look at those patients, so 90% of those were on the ICU still a month after start of treatment. So it was a very severe category of patients, and still just over 50% of those patients would have been back at home, independent for activities at daily living after 2 years. So that's not that bad for patients that were already 6 weeks ill and 4 weeks at the ICU generally, if we look at the big picture of those patients. However, if those patients somewhere in those 2 years, could be after 1 month, could be after 10 months, could be after 6 months or 21 months, recovered rituximab, cyclophosphamide, or both, then they would be distributed in the other group of the second-line immunotherapy, and in those we saw that over 3/4 of them would become independent for activities of daily living. Of course, this is not a trial, so you have to be very careful about confounding. We could not identify any, but that doesn't mean that there isn't. But if you would consider it like, okay, how many patients should you have to treat? It's about treating 4 patients to keep 1 patient, to get 1 patient back home independent overall, which is quite a nice number needed to treat. Importantly, this study did not make a difference between rituximab and cyclophosphamide, except for the children in which cyclophosphamide was used less. However, we were not able to see a difference between the efficacy of one of those 2 drugs or the combination. And I know that cyclophosphamide has a poor reputation, but I think that there's a lot of that this is most due to old data and also different ways of administering compared to how we use this now. It is one of the oldest drugs, one of the first chemotherapies. It's over 17 years old, and back then patients received more than 10 times the doses we provide them right now, and also in a different way with less attention to risks, safety, and so on. So I think that in general, the risks for new treatments are undervalued, and the risks of old treatment options we have are generally overvalued, and therefore we tend to feel like we should need the newest drugs for our patients, but it's not at all proven. Basically, for most of the new drugs, there's less evidence that they work compared to the old ones. Of course, this is controversial, and there's a lot of people that will not agree with me, but this is based on what data we currently have for NMDA. So if we look at all the new treatments, what options do we have? And this is a review by Harald Prus, already now 4 years ago, or 3-4 years ago. And so he mentioned the different treatments, and of course, some of the emerging therapies are more common now. For example, rituximab is still as emerging therapies, or CD20, CD19, but of course, this is no longer emerging, but widely used. But also some of these treatment options are probably not at all useful in NMDA. For example, there's not much evidence for complement, a big role of complement in NMDA, different from disease like NMOSD or myasthenia and Guillain-Barré syndrome. So therefore, it's probably not the most likely drug to use in NMDA receptor encephalitis. Of course, this did not mention CAR-T yet, which is also an option that is being used in incident cases for autoimmune encephalitis, and the first trials for myasthenia and stiff person syndrome are currently recruiting. but not yet for autoimmune encephalitis. And what you can see is that most of these drugs interfere with a different part of the immune system, partly overlapping, partly different. And right now, there's not so much evidence which one you should use first. If we look at what kind of data do we have, there is some data about tocilizumab, IL-6 receptor blocker, from South Korea, where they compared patients that received steroids, IVIG, rituximab, and tumor removal, if necessary, versus steroids, IVIG, rituximab, tocilizumab, and tumor removal, if necessary. And they, within their analysis, they found some effect of tocilizumab. However, there are some caveats with the statistical methods used, and the effects seem most convincing to me only in the patients that were really early treated with tocilizumab, within the first weeks after diagnosis treated with tocilizumab. But beyond, that was mostly due to, in my opinion, a statistical method problem. But we'll see, because in a minute I'll show you that there will be a trial on IL-6, which is currently recruiting. And the other option is bortezomib. There have been some patients reported from Germany where they show that patients resistant to or not responding to bortezomib did respond after start of bortezomib. It has to be considered this is only a very small case, series of 5 patients, and also if we look at NMDA receptor encephalitis in general and the response after rituximab, the median time to response is over a month. So if after 2 weeks you start a new drug and they start improving, can still be based on the effect of rituximab. What trials do we currently have? There's the Generate Boost trial from Germany, where they're looking at bortezomib, proteasome inhibitor. Then there's the Shallow trial from Roche that looks at satralizumab, IL-6 blocker, and unfortunately the anti-CD20 treatment trial from Southwestern was early terminated due to lack of recruitment, and also recruiting is the inebilizumab trial, which is a Neuronext trial from the NIH-funded investigator-initiated study headed by Stacy Clardy. And I'll only show you this very shortly, not to make too much, not to be too marketing. This is one way. This is a trial which is recruiting mostly in the US and also 2 European sites, or at least 1 currently, and Barcelona will be activated soon as well, and has been expanding to 12+. This is just a way how you could run a trial, because there's many problems about designing a trial for NMDA because of the severity of disease, the difference in age, the difference in the necessity to act quickly, the large amount of not registered trial medications that are used without license or without too many data to support the use. And as they are quite okayish available, it's not that easy to recruit patients. One way is at least that all patients should receive first-line immunotherapy. You will see in a minute that all trials will have this in common, and then they add on a additional therapy. And then you of course have to consider, like, okay, what is your primary outcome? When is my primary outcome? And what to do if patients do not improve? And of course there is this issue about adding placebo, but I think that despite the trial, the cohort study that we showed, and the meta-analysis from Nosadini in JAMA Neurology, they are all supportive of rituximab or cyclophosphamide to be effective, but that's not formal trial. There can still there's enough examples from the literature where the randomized control trial failed to show the same result as were found in cohort studies. In this trial, we added the option of rescue therapy after 6 weeks. Of course, as we're administering CD19, we cannot administer CD20 because that would not be useful at all in a patient that has already received CD19. So we chose cyclophosphamide, which can also, of course, be a matter of debate between people. So if you look at the 3 different trials, bortezomib, inebilizumab, and satralizumab, they're slightly acting on different ways. The satralizumab also has a basket trial, so they have an arm for LGR1, which I will not go into detail. The there's slight difference in age, in severity. Most importantly, the BOAST is an add-on trial, so all patients receive rituximab and then add on bortezomib versus placebo, which makes it quite difficult to have enough power, and it's probably a underpowered study. Generally, it's looked at 4 to 6 months what the outcomes are, and there's a difference in the way of dealing with rescue therapy and so on. But we'll have to await these 3 trials to see what are the initial trial results. So can we identify what patients will do well and what patients will not do well? We have been looking at serum, CSF, and CSF is a broad marker, but not a very good distinguishing marker. It has been published before that CXCL13 might be useful, but also it's mostly about CXCL13 remaining high is a poor sign. And of course, you don't want to do an extra lumbar puncture to have some information if that's all that you get. So it is difficult to use. NFL was published initially by the Danish cohort, where they said that there was some effect of NFL, but they did not correct for age. And the age-corrected data from Barcelona showed no effect for NFL and outcome. When we looked in our cohort, initially you would consider like, okay, higher NFL is associated with poorer outcome, but if you correct for age at onset, then it's no longer, so you normalize it, then it's no longer significantly associated to outcome. There's also an other issue with NFL, different from neurodegenerative diseases or MS relapses. What we see is that the axonal damage is not the earliest effect that you will see in NMDA receptor encephalitis. So if you would draw a second sample a week later, the sample would show a much higher NFL level. And in addition, the NFL serum is in a way also somewhat related to your steroid effects. And so the planning of your NFL sampling is very is not fixed within this initial days, weeks of NMDA, which makes the sampling diversity quite wide and the use in the general population more complicated. There's a paper that came out just this January from the French, where they looked into pediatric patients only, and there they identified an effect of NFL to be prognostic relevant even after correction for age. But of course, this is only in the pediatric population, where there is a much smaller difference over the age groups, and only like the smallest children have a slightly higher normal value for NFL. And also the timing, the delay the group is much more homogeneous compared to the adult population or adolescent and adult population of NMDA receptor antagonist. So maybe in pediatrics, there is some role for NFL in prognostic features. This is a score that was developed based on the 2013 cohort study and basically inverting the analysis. And then you could identify that there were several items that were related to worse outcome at 12 months. And this was ICU admission, longer delay until start of treatment, no effect within the first 4 weeks of treatment, abnormal MRI, and CSF pleocytosis beyond 20 cells. The big disadvantage is that 1 year is just one item, and patients can improve beyond the year, but also you have to wait 1 month into treatment before you can assign the NEO score. There has been this modified NEO score omitting this 4-week waiting, but this has a way worse area under the curve to use, so it's much less sensitive to predict the outcome. So I would not recommend using the modified NEO score. However, it would be much nicer if we would be able to do this at the time of diagnosis already. So what we did is that we combined cohorts from Germany, France, Netherlands, and smaller cohorts from Japan and Barcelona, and added those and put in a lot of quality controls, checks to identify all the data. And what we could see is that we could predict using a slightly different set of items, but already available at diagnosis, of course, the age. And what you can see is that this, the reason age was not in the initial NEO score was that there we used a continuous scale or a cutoff instead of using a J-curve analysis as we used with these the calculation of the NEOS2. And a J-curve just means that there is this optimum in adolescence, but if you're really young, you're doing a little bit worse. But especially with older age, you see that it seriously becomes more difficult to improve, despite the less symptoms and the less severity compared to the younger patients, as I showed earlier. ICU admission still is, time to start treatment still is a factor, CSF pleocytosis still is, only MRI was interchanged for movement disorder. And if we look at the NEOS2 score, combining the whole group, we were as good as the initial NEOS score at 1 month to predict a good outcome at 1 year using this MRS and complete ability to be independent for activities in daily living. But using almost the same NEOS2 score, we were also able to predict whether a patient would or would not respond to first-line immunotherapy within the first 2 weeks. And if not, you maybe should consider to directly continue with adding second-line immunotherapy, or and also return to work or school after 3 years as a use of a functional outcome scale. Of course, there's other scales beyond the MRS, like the K-score, developed mostly in NMDA patients, also looking at the symptoms of NMDA, and it's mostly important within the first 6 months, because beyond, there's this ceiling effect, as most patients will end up with memory or psychiatric symptoms, and then they do not improve or so much anymore. But still, despite MRS or Ks, we should do better, because if we're looking at symptoms patients complain about or do a neuropsychological evaluation, this is a pediatric study we did within the Netherlands, you can see that most patients are in the left under quadrant, meaning that they're sub-average on, for example, long-term memory or attention, quality of life, or fatigue. And also what we identified was only 2/3 would return to the same school level as before, meaning dropouts or lower level in 1/3 of your children. having a long effect for the rest of their life. Cognitive outcomes, as for example, shown here on the left by the Berlin group, where they show that most patients will have a lot of abnormalities initially, and that the amount of abnormalities will come down, the domains that they have problems on, measured by neuropsychological evaluations, will go down over time. And on the right is the study from Barcelona, where they prospectively followed 30 patients with NMDA, 30 with schizophrenia, and 30 healthy controls. Here it's the other way around. So the more you're inside the middle, the worse you do. So the green is the healthy control. And what you see is that over time, patients will show like a bigger graph, more appearing to be like the healthy controls, although they don't reach the outer layer, while the schizophrenics, of course, do not improve. We did a similar study with cross-sectionally in our group, and what we could identify is that most of the improvement is within the first 6 months, and then the cognitive domains remain improving, and we could see this improvement over 3 years, and then they stabilize. And this on the right side is prospectively using multiple time points within the same patient, where you see the same improvements over time. And if you combine all these patients, what you can see here is that the outside is more abnormal, and the red line is like considered fully abnormal, like the minus 1.5 SD, and the different lines represent the time from onset until this solid lines representing 3 years and over, which is mostly the most normal one. And on the right, you can see that within different patients, you could see the improvement within half a year or a year. So you could follow up patients by neuropsychological evaluations. Of course, if we look at patients beyond 3 years, most of the patients, of course, these are only the patients alive and able to do neuropsychological evaluation. 91% had a MRS under or equal to 2, but still 1/3 of the patients would have clear abnormalities on at least one domain, while 65% of patients had at least -1 SD at least one domain. The most affected domains within neuropsychological evaluation was memory and language, while the patients themselves complained most about processing speed and emotional well-being. And what we identified is that almost half of the patients, this adolescents and adults, did not go to the same work or school, 30% not returning at all, and 80% at a lower level. And this 48% is exactly the same as what was also recently published by the Berlin group, where 35% dropped out and 30% returned to a lower level. So this seems to be still a lot of work to do. What do we know about patient-reported outcome measures? There's no validated prompt yet, and we developed one using physicians, but also focus group of patients, over 200 patients with autoimmune encephalitis, cross-sectional, and then reducing the items using rash analysis, item analysis, factor analysis into a score that's 40, has 40 questions, and using NMDA, LGR1 and Casper2, about 100 NMDA patients. And what we saw is that you can see improvement over this PRO scale within the first 3 years, similar to what we could see in neuropsychological evaluations, and that they did not differ by age or educational level of the patients. They did correlate somewhat with MRS and quality of life. Of course, no perfect correlation, but if there was a perfect correlation, there was no need for a new score. So we would have been surprised if it would have correlated completely. And what you can see here is that if you're looking at the outcome in NMDA over time, there is difference. So you have the treatment response, which is the large group will respond within the first weeks. If you look at independence, or using the K-score, you can see that this improves over like the first half year, but then there is plateauing. But if you're looking at neuropsychological evaluations or prompts, you can see that this improvement is up to 3 years. And all of these scores have their advantage and disadvantage that I will not embark on today. So it's well treatable. It occurs at all ages, can be less encephalitis than an infectious encephalitis. The phenotype, but also the treatment response differ by age. There's still much unknown about the long-term outcome, but we're getting there. There's definitely more need for better rehabilitation, and the NEOS-2 score probably is able to predict outcome at time of diagnosis, but also might help to guide treatment decisions. And with that, I would like to thank all the people that actually did a lot of the work that I presented here, and all our collaborators and funders. And I'm open to have some questions now, or I have also 2 cases that we could discuss and have some interaction about what to do next.